Good afternoon, welcome. Thank you all for coming this sort of day trying to decide whether it's raining or not. On behalf of Dean Uda Poiga from the College of Social Science and Humanities and Dean Terry Fulmer from the Bay College of Health Sciences, I want to thank you all for coming and being here today. We're excited about the conversation and the ability to sort of learn from each other as we go forward. One of the things that is a hallmark of the way Northeastern is moving forward in doing its education is to understand that some of these problems are so complex that any one of our disciplines, no matter how important we think our discipline is, can't really address it fully. The only way to really get an understanding of problems is to look at it from a variety of different lenses. And I think that that's one of the things that's a strength of this, of what we're doing today, of what we're trying to do here at Northeastern as we move forward. I think that the Institute for Global Health is an opportunity for groups to come together and bring different perspectives. Bring perspectives on health and health care delivery systems, but at the same time, perspectives on public policy and how to implement policy that will make changes and try to work together to try to understand that. So we try to model that here at Northeastern, sometimes more successfully than other times, but we're trying to model that again here today. I think there's an opportunity to learn best practices from each other, but also to understand that a best practice is tied very closely to the culture that it comes from. And best practices don't work unless we understand the culture and understand how to make that practice work within a different kind of culture. So that's the richness of today and the part I'm really looking forward to the conversation and learning a lot more from each one of you. Thank you for coming. I'm going to turn the conversation over to Eli Harrington at this point. Eli is the Manager of Programs and Operations for World Boston, and he's going to tell you a little bit more about World Boston and the role that it plays today.
Thank you very much. Thank you all very much for being here. It is my distinct honor to be at this podium and to be involved in this event representing World Boston. I first wanted to thank our event sponsors and our hosts here at Northeastern University. We have a very close relationship with Northeastern. They have been extremely supportive in walking the walk as far as their commitment to international collaboration in many different respects, and also to acknowledge a current Northeastern student who is a co-op at World Boston and has done a huge deal in helping to set this up, Ms. Therese Berger in the back. So thank you again, Therese. And next to her, Erica Ross as well, who's been one of our main liaisons in setting this up. So thank you both again very much. World Boston is we are a small nonprofit, small as far as staff, but not as far as ambitions. And I like to say we try to bring the world to Boston and Boston to the world. And there are a few different ways we do this. One is through hosting numerous speakers and events, an author series, a young professionals and students network, as well as various events with the Consular Corps, the business community. And the other side of it is as a member of the National Council for International Visitors to work with the Department of State to coordinate the International Visitor Leadership Program. This is a program that is certainly not new, and despite all of the budget issues in Washington, which some of us know more intimately than others, has remained steadfast and strong because it is very highly regarded as one of the best things that we do as far as our foreign policy. To give you all just a little bit of context about this program and how we're all seated here in this room together today, one of the things that our embassies do across the world is identify catalysts for change and leaders in many different sectors and put together professional programs to bring these folks here for typically 3 weeks at a time, where they will travel to various locations around the US so they can appreciate our geographic and political and cultural diversity, but to really have these programs be arranged around professional topics so that there's an immediate benefit for both the American practitioners and our international and their international counterparts, I should say, who can share information and best practices in their respective cultural contexts, as was so astutely pointed out, but also really to build on not just the professional exchange, but also to give these future leaders and current leaders an opportunity to experience American culture and government authentically. I'm an alumnus of Brandeis University, and Louis Brandeis used to say that, or the Voice of America used to say, we bring the truth, warts and all. So this program is really about authenticity and about genuine exchange. All of our professional appointments are off the record, so that people can be clear. Tonight our presentation is being filmed, which are very fortunate to, and I thank our visitors for their willingness to speak on the record and be photographed. So I did want to acknowledge, besides our panelists, our entire group, and I'm going to put them on the spot here a little bit and ask them if they would please, because this is an incredibly diverse group who are representing many different cultural and geographical contexts, but an amazing lineup to give everybody sort of an idea of the caliber of professional that are making up this group. So I'll just ask if we could go maybe from the front row, if all of our visitors could stand up one by one and just announce their name, their title, the organization they represent, and the country from which they are coming. And I'll start because you made eye contact with me. So our gentleman on here to the left.
Yeah, hi, good afternoon. My name is Jose Ledesma. I'm from Dominican Republic, and I represent the Department of Technical Assistance in the HIV National Program within the Ministry of Health.
Thank you.
Hello, my name is Carlos from Panama. I work for the Hebrew Immigrant Aid Society. We work with refugees and people in need of international protection.
My name is Anita Berfo from Ghana. I work with Koliku Teaching Hospital, Ministry of Health. I work with the HIV department. Our main focus is prevention and treatment of HIVs.
Hi, my name is Saisana. I represent the Population Services International. It's the NGO. I'm from Laos.
Good afternoon, my name is Fuisa. I represent Eastern Cape AIDS Council. I'm from South Africa.
I'm from and I represent Stop VIH, which is an NGO from Venezuela.
Hello, my name is Marian. I'm coming from Romania. I'm working for a local NGO called Carousel.
Hello, good afternoon everyone. I'm Prasun. I'm from Nepal and I'm working on the program that's supported by the World Bank. Its focus is mainly for the MSM, menstrual and transgender. It's a comprehensive package for HIV. Thank you.
Hello, my name is Steve. I'm from Nigeria. I work with Project Hope. We work in the media-based intervention where we train journalists. We work in the governance and accountability sector of the response in my country, and we work with the sexual minority group.
Good afternoon. My name is George Kituka. I work with the Ministry of Health in Kenya, National AIDS Control Program, coordinating HIV prevention and control amongst the key populations.
Hello, my name is Momchil. I'm from Bulgaria. I'm coordinating the health programs at Center Malipe, including HIV and AIDS. Thank you.
Hello, my name is Yael. I'm a social worker and I'm from Israel. I represent STD and HIV clinic in Tel Aviv that belongs to the Ministry of Health and serve also neglected population, not only there. Thank you.
Hello, my name is Yelena. I'm from Russian Federation and I represent the Russian Harm Reduction Network, which is the work that drug users and sex workers in Russia. In 35 regions of Russian Federation, most of that.
Hello, I'm Yuta from Estonia. I'm a physician in Mistville Central Hospital and in prison.
Wonderful. On behalf of all of us, thank you all for being here and welcome. It is our honor to have you. Thank you. And before I turn the floor over, just one quick note for our audience. Many ways to get involved with World Boston as a volunteer, as a student, and as we say, these visitor programs as a citizen diplomat. Everybody has a right, if not a responsibility, to participate in our international affairs, and meeting and speaking with these visitors and sharing information is a great way. So I encourage you to ask them some questions, share some information. As I tell all of our visitors, we hope that this trip is the beginning and not the end. So without further ado, thank you all again.
Well, as you can just tell from the introduction, we have a wealth of experiences and perspectives that we can learn from today, so that's wonderful and what we're really looking forward to. the way we're going to structure this is to have some brief presentations from a number of folks from Northeastern and from World Boston and the visitors program. And then we're going to have a question and answer, and that's where you're going to get a chance to have your questions asked and sort of have a conversation, learn some things on your own. So I think it's important that we have both, and we've got it structured in a way that will happen. So what we asked to kick it off is the co-director of the Institute of Global Health, Rich Womai from the African American Studies Department here, who's been doing incredible work in neglected diseases, and both here in the United States and in Africa. Rich.
Well, thank you very much, Jack, and thank you so much, Ellie, as well, and bringing your team here. Teresa, I would also like to thank you for approaching us to organize this event. I also want to thank all the visitors and also my colleagues, Brooke here and Jen. So what I would like to do is just make a few remarks. We thought that we could share a few remarks with our visitors here with regard to the work that we are doing. Most of my research is in Sub-Saharan Africa, and I work on HIV and AIDS. In fact, I'm glad to see one colleague here from Kenya, and also all of you. So I'd like to make a few remarks with regard to HIV, particularly here in the US. And the way I thought about this is a lot of information that we could cover, and I'm sure too in the visitors in your travels around you have come across some of this information. I do some work among immigrants from Africa on HIV here, which I started in 2009. And probably I just framed my comment by observing how I got engaged in this. In 2009, in the spring, I was approached by a Ugandan lady who was working with JRI Health, which works with the Massachusetts Department of Public Health. And they had a concern that the data that was coming in for new diagnosis showed increasing infection among African immigrants, about 30% increase over the previous period cycle of measurement. And so they wondered what is going on among this population. So we did a series of 4 workshops with Kenyans, Ugandans, people from Cape Verde, and Ghana in different parts of Massachusetts. And so that generated some interest for me to try to understand what's going on, and meeting these African immigrants here in Northeastern in different places generated some interesting observations with what was going on. So I framed that, and then want to just make a few remarks with regard to HIV here in the US. And the current data that is available shows that there's about 1.1 million persons living with HIV in the US, and I'd just like to make that one data point to observe there. But then there are other things. We know that there's a gap between those who are infected and the percentage of those who know that they have HIV. The figure is higher in African countries compared to the United States, but even as you see in the US, there is a gap with regard to those who don't know their status. Also, with regard to one of the goals for treatment is to reduce viral load. So viral suppression is a key target goal for treatment. Brooke will be discussing that in a bit of detail, but you can see in the United States, the viral suppression has not reached very high. So it's about 25% of those who are on treatment and are receiving treatment to achieve viral suppression. The other thing is that data for HIV, there's a story that I tell my students in HIV classes. The current existing literature shows that HIV would have emerged from Western Africa, Cameroon and Guinea, and then traveled to Haiti, and then around 1969-72 would have come to the United States through a single case from Haiti. So, and then around 1981 is the first year in which the first diagnosis was made in the United States. So since then, data has been tracking what has been happening. This image here tells multiple stories, but the one story I would like to observe is that with regard to the death, there have been decreasing death since the mid-1990s, diagnoses have also declined since the 1990s, but obviously prevalence has continued to grow as death decreases and those who are living with HIV continue to live longer. So if you were to look at the structure for the epidemic in the United States, we know that most infections occur among constituted populations, non-vaccinated men, injection drug users, and those at high risk. And then we also know that there is a growing proportion of heterosexual transmission. So if you were to look at heterosexual transmission, what are some of the key structural elements with that? We see that on the population, in the general population that are heterosexual infections, substantial poverty plays a role. Some of these factors here, to me, seem similar with sub-Saharan African countries. Even as you can see here, it is mentioned lack of condom use or low rate of condom use, and even fewer men being circumcised. There has been a lot of studies done on cost effectiveness. In this state of Massachusetts, in 2008, there was a case that was brought, there was a petition in the Massachusetts State House here, State Senate, and that case was brought to ban male circumcision, voluntary male circumcision. I received this information and then we lobbied, wrote to the senator, and the senator assured me and the group we were working with that actually this case had been brought in because somebody had requested that the case be brought to the front. We know that I work a lot in male circumcision, and so this is a field that I'm very passionate about. And so the state here did vote to ban circumcision. But in 18 states in the United States, there is defunding for Medicaid support for male circumcision. Those of you who are from sub-Saharan Africa, you know that there are 14 countries in which there is scale-up circumcision programs to achieve prevention. So I'll move on and just observe that if you look at this is diagnosis of new infections among adults and adolescents by race and ethnicity. African American men, particularly men, but also women, have an increased rate of diagnosis, much higher compared to the racial categories as white, Hispanic, and others who are very down here. So that is one thing, a message we know that infections are much higher among African American population. If you were to look at infection by population, again, diagnosis of infection, this total number of infections, 2009 for only 40 states, you can see that among Black African American, there were 52% of the infections in 2009 in 40 states were African American, but African American comprised only 13% of the US population. So an increased rate of infection in that population. If you were to look at the infection, the diagnosis of infection in this population by sex and transmission category, you can see that for men, male-to-male sexual contact is significant. This is 68%, and this is for African American or Black population. And this proportion is generally higher among all racial categories, so the proportion of infection in MSM is high. But for women, for all racial categories here, among African Americans is 87% heterosexual transmission, but for racial categories, female transmission is typically heterosexual. This shows a different story with regard to AIDS diagnosis among adults by race and ethnicity. You can see that in AIDS diagnosis, there's a growing, this seems to be probably the only substantially growing population that has AIDS diagnosis. The Black African American category, for whites, it's been coming down since 85 to around 2009. So it tells a disparate story. I would like to end my comment there by observing that if you were to look at HIV diagnosis and distributional prevalence in the United States, there are some areas where it is generally much higher. We know, for instance, Washington, D.C. is significantly high. In fact, in a population survey in Washington, D.C., the prevalence among African Americans is higher than the national prevalence in Uganda. That is a proportion prevalence in African American men being significantly much higher. So I think that there is this sort of emerging new epidemic among African Americans in the United States. I think it is generally being a forgotten epidemic. There was a series of seminars which were held last year and the year before by the Center for AIDS at Harvard. I attended one of those sessions in Washington, D.C. We went there and visited the state, the U.S. Capitol, and lobbied some of the senators. We met the Massachusetts House representative there, and the goal was to try to lobby these politicians because the epidemic that is transitioning, as we can see here, towards African Americans is generally somehow seemingly being forgotten, and we need to lobby much harder in order that it can be brought back into the political discussion. I will end my comments there, and then invite Jose Amilcar. Okay. All right.
It's really a pleasure for me to be here in front of you. I'm going to be talking, representing the 3 Latin countries that are in this group: it's Panama, Venezuela, and Dominican Republic. I want to say that within our countries, the prevalence right now is in a range of, in a media of 1%. In some countries it's 0.4%, in other countries it's more than 1%, but the media is 1% of prevalence of HIV. The infection is more acute in females. Due to this population, is more detected due to the PMTCT activities that are undertaken on our country. But also, the concentration, the epidemic is now concentrated. What does this reflect? There is not more increase in the general population, but is more increase in the most at-risk population, such as drug users, men who have sex with men, and sexual workers. This leads us to some specific intervention that we have to make within this population. One of the huge problems right now is that our prevention programs are not really strong and not receive all the support from the government or from the NGOs that are working. In some of our countries, the intervention has to be made from the NGOs, and this means that there are not a lot of resources that are invested within this. One of the other things is that we are suffering right now in almost all the Latin countries are the stockouts in antiretrovirals and in reagents for CD4 and viral loads, where the tests more requests are needed for the HIV patient. So right now the regions try to make like a huge response to really approach this problem, since the resources are really falling down to the donors, and the countries has to really focus within their Ministry of Health to identify where the resources are going to come from. Some of these countries, except from Venezuela, but some of these countries receive the fund from the Global Fund, and the Global Fund, as you may know, is now moving out of giving money to our countries, so now we have to be focusing more within our own resources. I don't know, this is more or less an overview that we are prepared for the Latin region. But as we, also one thing that we identify here is that we, as the United States, has really a huge gap in testing. We have a huge problem because we now don't have really good intervention, and the population is, we have a really under identified population that don't come to test. So the gap that we have, we don't know how really, and in all the visits that we are making, we really ask that how we can approach to identify those populations that we are really now not identifying. So this is almost an overview of the Latin response at the moment. So we are really open to see any question or suggestion from you.
Right, so then we will have Jim, please.
Thank you so much. It's a privilege to have people here from around the world, and some of us that are here with you today have had the opportunity to travel and spend time in your countries. And I want to give a big shout out to the Eastern Cape, many good friends there. So I actually wanted to start by a remembrance that I thought we could all share, which is that it's 15 years since Jonathan Mann died. He was both a close friend of mine and a colleague in his time here in Massachusetts as well, WHO. And he has a quote that he said early on as the epidemic has been evolving: people marginalized, discriminated, and stigmatized before the arrival of HIV/AIDS have increasingly borne the brunt of the epidemic. Therefore, to uproot the epidemic, it will be necessary to deal with its root societal causes, namely lack of respect for human rights. And I think there's nothing that we're going to say today about the ways in which the disease is getting concentrated in populations, where those populations are situated in our country or yours, that frankly is different from that initial analysis. His approach to thinking about that was deeply situated in understanding the necessary roles and potential both contributions and barriers of all the various sectors we represent: governmental, NGO, the larger polity, industry, that somehow the answer had to come across those diverse terrains. In that context, in a way he inspired me particularly, and I guess at this moment I want to speak specifically to the people who are coming from other governments, that as a person who has been in and out of government, he really helped me to appreciate the role of stewardship in government, which is a challenge in terms of understanding our obligation to bring order and resources to emerging threats like HIV/AIDS, SARS, many others, and our responsibility to facilitate collaboration across sectors, which is not always easy because there are many reasons that people don't trust government, well, at least in our country, maybe in some of yours, at different times. Like, I cannot imagine a time 30 years ago when I was working to begin with in the epidemic, where some of your countries would have talked about the work you're doing with MSM. There was no conversation about it. There was very little about it here. So working across our sectors and the opportunity to bring a different kind of vision through the facilitation of government and NGO, different times, different parts of our sectors have different kinds of strengths. And his important lesson to me, I worked with him as an academic. I worked with him as somebody that was running a national AIDS organization that was an advocacy group, an NGO. And then I worked with him as a government administrator. And his message to me was that I did not need to see those roles as inherently adversarial or conflictual, that I needed to imagine how did you build the bridges so that you could be successful. And it's from that vantage point of intersectoral collaboration that I both remember him and speak a little bit today, because even though the epidemic is 3 decades old, our struggles remain much the same. I mean, that's not to wipe out the incredible knowledge development in basic science and behavioral science and the armamentarium of therapeutic regimens. We've learned so much. It's not the same disease, and in fact, we've changed the course of the disease. We've concentrated it in the margins to a great extent. And so the challenge of assuring that those who are at the margin are not differentially impacted has in some respects during this time actually gotten worse, because the backdrop for the world is that income disparity has gotten greater. Gender economic parity, which had been improving, has totally stalled. Gender violence is actually on the increase again. The promise of treatment access, which we just heard, is really threatened in this country to some extent, although we have hope for healthcare reform, but very much by donor changes. And so this is a terrible struggle in the face of higher prevalence and greater need. and the risk of tolerating a steady incidence, like it's almost okay that it continues unabated in the margins in our countries, because at some level it's less visible than it was before. It's been obscured by the improvements that we've made and by the push to the margins. So in the US right now, Richard's first slide showed you an unfathomable, from my point of view, 25% of individuals who are fully suppressed in terms of viral load. We should be embarrassed. We are not sufficiently embarrassed. And that's in spite of almost universal access to medication, even though we don't have universal access to care yet. And that's permitted the kind of differential risk that he showed and talked about in the South, in men of color, and particularly among those men who have sex with men who are from communities of color. And it's the same time we have contributed further to denying the ongoing expansion of untreated and undertreated substance use and mental health disorders that are bringing us a co-occurring rise in hepatitis C infection. So this is a bad confluence of a backdrop of economic disparity that promotes all the disparities that we've talked about and further impacts the resources that we need. So to stymie the epidemic in this country, we really rely first and foremost, and this is how we share so much, on making sure that people get to know their status. 30 years later, we're still struggling with the stigma associated with it, with the access to the testing in a reasonable way, and with the immediate care that needs to occur even if you don't go right onto treatment. We have to continue to confront homophobia. I'm happy to say that I was couple number 10 getting married to this whole country in the state of Massachusetts here, and I think we're up to 10 states that have marriage now. But that doesn't get rid of homophobia at home or in other states, and that's why we see what's going on with men who have sex with men of color. We have to address the diverse promoters of the disparities that we have in our racial and ethnic communities, and they are largely but not solely economic, because our own history of slavery continues to inform practices of diminishing people's opportunities. We also have to deal with the margins that are part of the engine of the epidemic in terms of substance use disorders, incarceration, and immigration. Many of you know we're struggling with immigration reform right now. And finally, we have to promote positive sex and sexual health and appreciate that in the absence of that, I tell my students all the time, I want everybody to graduate from here in the health sciences and go and talk about sex and drugs all the time. Because I'm convinced they're both two things that people enjoy, and they're also two areas where the risk is great if we don't, in fact, engage the conversation. And so that's going to be important as we look at healthcare reform in our system, that we really engage behavioral health as well as medical care, that we integrate HIV better in terms of our overall primary care. Many of your countries actually do that better than we do. And that we think about how we're going to incorporate the new biomedical opportunities that create their own challenges, like pre-exposure prophylaxis. So doing this well means working across our sectors. Working across our sectors means imagining that the NGO and the governmental administrator and the physician and the consumer, him or herself, and industry can be partners. I look forward to a further conversation. Thank you.
Thank you very much, Professor Maguire. Then we are going to have Momchil Kostov-Bayev from Armenia, please.
Bulgaria.
Bulgaria.
Hello everyone. Thank you for this opportunity. As you heard, my name is Momchil from Bulgaria. I am not sure if I can represent the whole region of Eastern Europe or the part of the world we come from, but I will try to give a few highlights of the challenges we face or the accomplishments we have. In the first place, I would rather say a few words of the HIV prevalence in the region of Eastern Europe, which is relatively low, but that is not the case of countries like Ukraine, Russia, or Central Asia. I would say that this is thanks to the funding of the Global Fund that's been investing a lot of money for more than a decade in the HIV prevention and control in the area, not only HIV, tuberculosis as well. So for instance, in Bulgaria, the HIV prevalence is 0.1% of population approximately 7.5 million, which is very low. Of course, the estimates of UNAIDS say that the number is actually 4 times higher, but we know that a lot of people just don't get tested. We're not there yet. Also, as we saw on some of the slides here, the most affected populations are similar in our region. The most heavily hit are the men who have sex with men and injecting drug users. So we have a lot of things in common here. I'd rather speak more about the challenges we have in nowadays, and the biggest one is probably the funding issue, and this is a difficulty for all the countries in the Eastern Europe area or the WHO European region in general, which includes Russia. So the funding that the Global Fund provides is ensured only until the end of 2014, and many governments are facing the question, what are we going to do after January 1st, 2015? The sad part is that some governments have no clue what are they going to do. Even I personally spoke to people working at the Ministry of Health in Bulgaria, and in fact they don't have an idea how they're going to fill this huge gap of resources. Unfortunately, the state budget is completely not enough to fill that gap. We don't receive funding from donors like Clinton Foundation or the PEPFAR. All the money that comes in HIV prevention and control and tuberculosis is from the Global Fund. And thanks to the United States that it's supporting the Global Fund very heavily, and it's going through replenishment right now as we speak in this week. Another major issue in terms of HIV in the area, I would say, is the lack of leadership among communities affected by the virus. At least in Bulgaria, the communities that are affected are not really represented by either community organizations or of any other kind. So there's several NGOs who work with HIV positive individuals, but they're very small organizations, they're very weak in terms of advocacy abilities. So there's a great need of capacity building. And that would need more than just resources. It takes a lot of work, and it's a process that will take a while. Another issue that I see in the area of Eastern Europe is the comprehensive HIV care. We had a chance to visit different community organizations in the US, to speak with government officials, to visit clinics, and the comprehensive HIV care is key to the well-being of the HIV positive individual. Unfortunately, a lot of doctors and HIV specialists in Eastern Europe have the understanding that HIV is just viral load and CD4 count, which is not the case, of course. So I'm really hoping someday we'll have a comprehensive HIV control or HIV care in that part of the world, because what we see here, I would say, is the best model. Of course, it does not cover the entire country of the United States, but at least a large part of it. Another point that I wanted to make is that yesterday with some colleagues who were walking around the city of Boston looking for events devoted to the World AIDS Day. Unfortunately, it fell on a bad day, and there was not many things happening. We passed by a few churches, and they were distributing the red ribbons, so we got those. We walked a lot, almost the whole day, looking for major events or a march or anything that was taking place. We could not find anything. Some of us looked in the paper to see if there's anything going on. There was nothing on the paper. So I wonder, why would a city like Boston did not have anything huge on December 1st? Not that we have to speak about HIV prevention and control only on December 1st, but it would have been nice, I guess. And one last point that I would like to make is the universal access to treatment. Are we there yet? And my colleague mentioned the shortages of drugs that we see in some countries. That is not only in Africa, in Central and South America. That also happens in Europe. And you believe it or not, it happens in the European Union as well. Countries that are member states are believed to be developed countries, or rich, some of them. But the shortages of drugs also happen in the European Union. And we see that very often. So I would like to finish here. The lack of access to treatment, to antiretrovirals, is a heavy violation of human rights. Thank you.
Thank you very much, Monsieur. So we'll have a speaker from Nigeria, Mr. Olubisi Stephen Aborisade. And what a pity with regard to your tour yesterday, you didn't find many events. I think it's really a pity we didn't have a lot. Maybe the weather was the weather. But I looked at a list of World AIDS Day community events. They had a number of them, not too many, but they sort of spread through the week. So maybe we missed some of those. But please, Mr. Olubisi.
Good evening, and thanks for having us here. I am from Nigeria, and I'm representing my colleagues from Africa. Our own case is peculiar because we carry the largest burden of the epidemic. In Africa, if you're not HIV positive yourself, you must have a family member who is either positive, a friend who is positive, a cousin who is positive. We are all really affected. And as I talk, there seems to be really no hope. What do I mean? Generally in Africa, and this is the situation, all over Africa, there's extreme poverty. There's serious inequality. There's insincerity in the interventions in the various countries. There is illiteracy. Inequality, I will put that into two. One is gender inequality, because the majority of those who are affected are women, and they continue to bear the brunt of this disease. And that's fueled largely by our culture and traditions. Then, the media, because in Africa, we basically depend on the media to define our reality. But we have a media institution that itself does not understand HIV. So rather than give education, it promotes fear. It helps in the misconceptions that people have. Then we have corruption almost all over Africa. So you find a situation whereby resources that are meant, for instance, I'm from Nigeria, a very rich country, the largest oil producer in Africa, the 10th in the whole world. But I tell you, our HIV intervention, Nigeria only contributes 1%. We have a population of 3.6 million people who are HIV positive. Out of this number, less than 400,000 are on drugs. And our leaders, if you go to Switzerland, across Europe, they've started serious money. They steal. It's rampant across Africa. Then is the fact that most interventions in Africa are not really driven by any thought-out policy. They just sit down and the funders come, this is what they want to do. It does not really matter whether it matters, it aligns with the challenges on ground. We get the money because the big interest is the money that comes in. So we don't have a policy. We don't have a structure of intervention. When you come to my country, for instance, you see a lot of people doing this, replicating the same ideas, whereas the most important sector are being neglected. All over Africa, the key most at-risk group are being driven to the closet. For instance, I mentioned the sexual minority. Across Africa now, the trend now is the anti-gay bill. My country's parliament just passed one, waiting for the president's assent in Uganda, everywhere. We call it the gay bill. If you identify as a gay man in Nigeria, if you even relate with a gay person or an organization working on HIV, working with people of that orientation, you can go to jail. It is a reality. We have instances where people, they burn them alive, they kill them. We have several interventions, and sex workers. There is a discrimination that comes with being, in that line of work. Then people in the community, the social reaction is the fact that you have gotten what you deserve. So, no health intervention for sexual workers, no health intervention. There's nowhere anyone who is gay can access treatment. Nowhere. Wow. And every day the population is increasing. It's increasing. It's really bad. Between South Africa and Nigeria, we account for almost 10 million in population of people who are HIV positive. We have an increasing number of AIDS orphans. Right now in Africa, we have a new generation of grandmothers who are coming back to take the basic role of child rearing, having lost their father, their children. It's sad, and these people, they are quite old. In Africa, when everywhere, all over the world, they are thinking of an end to AIDS, we are hearing news about breakthroughs in treatment. In Africa, we cannot think of it. For instance, in my country, I brought a sample drug, which I have given to folks at the State Department. We have issues of substandard drugs being given to patients. Yesterday, I lost a friend based on this issue, and they are now helping to determine what actually is the content of that drug. It's a big issue. HIV/AIDS is basically seen as business. We have a growing number of government officials who are thanking God for HIV/AIDS, because that's another way to siphon public funds, because a lot actually goes into HIV/AIDS. The Global Fund has had calls to stop funding Nigeria at a time because of corruption. It's really bad. Not just Nigeria, everywhere. You see our officials riding jeeps, whereas people don't have access to the basic drugs. People are dying. So we have an increasing population of orphans. We have more the grandmothers now coming back to the role of being mothers. We have a workforce that is now seriously affected by HIV/AIDS. And that speaks volume to the future of our economy as a continent. And the lean resources in Africa, HIV/AIDS is really putting a serious stress on it. It's really sad. And I must tell you, in my country, of a country of 170 million people, with 3.4 million people living with HIV/AIDS, there is no legal authority, there is no law, there is no provision in the Constitution that expressly guarantees the right of people who are HIV positive. There's nothing will happen. People are being sacked from their work, nothing happens. Hospitals will refuse treatment, nothing will happen. Status, if I go for a test and I test positive, they can disclose my status even to my family member before I know. And these are great challenges. And we wonder that, and I say, I want to see a situation whereby the US gives money, but the US should at least, demand for accountability, demand for governance across Africa. That is missing, and that is necessary. Thank you.
Thank you very much. We see, I think that's very invigorating talk. Thank you so much. Nigeria, I had a student from Northeastern who went to Nigeria to work with the Clinton Global Health Initiative to help Nigeria submit the application to the Global Fund. He came back after 2 months in Nigeria and he told me he knows Nigeria is not going to get the money. He knew as he came that the country would get it, and he didn't get it. And, but he worked and then submitted that as his master's thesis. So that's a sort of a great, interesting point. So thank you very much. We are going to have another talk. We have some time for questions. I'll invite Professor Brooke Baker from the law school to close this presentation.
A hard act to follow, but I'm glad to follow it because I'm more optimistic than that. I'm a global AIDS activist. I work in access to treatment, and I've seen tremendous progress and tremendous steps that still have to be taken. So I hear my colleagues from Africa and the description of what you're experiencing, and yet I still see tremendous progress on the continent. I became involved in HIV/AIDS having worked at the University of KwaZulu-Natal in Durban in 1997. And when they did anonymous testing among the student body in 1998, 30% of the students were HIV positive. The Black African students had a much higher rate than the Indian students. And even today in Durban, the antenatal infection rate is still almost 40%. So this crisis has not ended. And yet at the same time, as we'll see shortly, South Africa has over 2 million people in treatment, probably 2.4 million people in treatment. They overcame obstructionism by the US and by the US drug companies. They overcame obstructionism by a denialist government. And now they put that many people in treatment, basically just in the last 8 years. Remarkable achievement in South Africa. So here's just global statistics from last year. 35 million plus people living with HIV is the estimate. 70% of those, approximately 70% in sub-Saharan Africa, 25 million people. What's changed dramatically in terms of response to HIV is that there used to be the perception that treatment and prevention were in opposition. If you spend money on prevention, that might be more cost effective, that would reduce new cases. It would be too bad if people infected died, but that might be the consequence. On the other hand, the major energy in the global AIDS movement was for treatment. It was people who came together, demanded from their governments and from scientists and from the world in general, we deserve to live. When we found medicines that cured, that didn't cure, but helped stop HIV from progressing in the US, people in the global south demanded that same treatment there. Basically, the idea was, if it's good enough for rich people, it's good enough for poor people. If it's good enough for people in the United States, it's good enough for people elsewhere. Well, the opposition between treatment and prevention is no longer true. We had a major study in 2011 that showed if a person received antiretroviral therapy, 3 drugs at once, and if that treatment was taken consistently, and if it was successful as it normally could be in reducing viral load, the risk of transmission to partners was reduced by 96%. In other words, instead of 17 people potentially being at risk of infection, it might be only 1 person. So now we have a world in which when we fulfill the human right to health, the human right to treatment, the human right to have your life extended, that also has communal benefits for the community. So now we have a situation where treatment is as prevention. It is important for prevention and it helps advance that cause. So here's the treatment numbers since 2002. And this is one of the reasons I'm a little bit more optimistic about Africa than you just said. In 2002, there were less than 200,000 people on treatment in the entire continent, well under that number. And now we have 7.5 million people on treatment. The gray area is the people on treatment in Africa. 7.5 million people into 2012. And a global total of 9.7 million. If we add the people put on treatment this past year, we're quite likely to be over 12 million people. Between 11 and 12 million people on treatment. Now you see the other areas represent other regions of the world, and progress has not been dramatic elsewhere as it has been in Africa. But that's basically because we went from 0 in Africa. So what's happening with the coverage, and who's getting treated? When you look at the WHO guideline from 2010 and what percentage of people who were eligible for treatment at that point were on treatment, you see that 59% of women were on treatment. And that's mainly because women were accessing care through antenatal services. They were being tested while they were pregnant, they were being offered voluntary access to treatment, and so treatment was relatively good. Surprisingly, because men often have preferential access to treatment for many other health conditions, for HIV, at least in the global south, that's not true. Men, in fact, are underserved with respect to access to treatment. They had only 41%. But children were by far the worst off. They had the least access to care as a group, except for the stigmatized groups that we've been talking about at some length in this session already. We don't actually know the percentage of men who have sex with men, injecting drug users, and sex workers who have access to treatment. But where the limited studies have been conducted, it's often a tenth of what the general population access is, and not getting much better over time. So, we've reached 9.7 million. We have, under new WHO treatment guidelines, almost 29 million people who are treatment eligible. So it depends on whether you're an optimist or a pessimist. I say the glass is 2/3 empty. Because my sense is, and I'm sure it's a sense of everyone here, that everyone who is infected with HIV, everyone who needs treatment should have immediate access to the best possible medicines and diagnostic treatments. And so this is the group of people who are eligible under new WHO guidelines issued just this past summer, who are now eligible for treatment because it's good for their health and it's also good for prevention. Even under the WHO guidelines, there's still a stated preference for people who are the sickest, which of course makes the most sense. But as we also heard in the United States, there's a movement towards, or actually a principle of universal voluntary access to treatment. In other words, in the US, an HIV doctor will ordinarily offer treatment to any patient who's HIV positive, regardless of CD4 cell count. Because in the US, the assessment of the benefits of that treatment versus the risks and unknowns is highly in favor of treatment, and both for individual benefit and for prevention benefit. So we talked a little bit about the treatment cascade. This is just a comparable figure or diagram to the one that was shown concerning the US, and this is the treatment cascade in Africa. And what's pretty remarkable is, or excuse me, in sub-Saharan Africa, what's pretty remarkable is that sub-Saharan Africa is doing almost as well now, today, as the US is in connecting people to care. Now, I heard someone say that the US has one of the best available systems for connecting people to care. Actually, the US has a pretty bad system for connecting people to care. When you have community health workers, when you have community-based services, like many of the African countries are now rolling out, you actually get better treatment outcomes, nurse-initiated care, in some cases even community health worker-initiated care. If you have simple treatment regimes, if you have steady supply of medicines, then you can achieve these results. We can't talk about South Africa today without talking about the stockout problem. I mean, major report just issued by the Treatment Action Campaign in Section 27, outlining what is really a failure of government planning and follow-through, where virtually 20% of the health centers in the country have had stockouts of HIV and TB drugs over the past 3 months. This is just the US statistics that we already saw on treatment area. Now, where are we in funding? People talk as if the funding decline is inevitable, and I don't think it is. We had about $19 billion globally on HIV spending in developing countries in 2012. The green line is donor funding, and donor funding has been going down the last few years. It's been flatlined. Spending by countries has been going up, and so now most of the funding in the global south for treating it, for responding to HIV is actually from developing countries themselves. The line goes up towards a goal, which is about $24 billion per year. So we're short in terms of what we need, about only $5 or $6 billion per year. That's not a lot of money. I don't see how anyone can talk on World AIDS Day as if we cannot come up with another $5 or $6 billion out of the global economy to respond to HIV and have a comprehensive access to treatment. So this is some of the things I campaign on as an AIDS activist in the groups I work with. We're trying to get the U.S. PEPFAR program to commit to treating 12 million people, supporting treatment of 12 million people by the end of 2016. We're trying to get WHO and UNAIDS to have a very ambitious target that by 2020, 30 million people will be on treatment. We want to fill the funding gap, the $6 billion a year I just mentioned, but also the replenishment that's happening for the Global Fund just today and tomorrow, where the Global Fund is seeking $16 billion for the next 3 years. Didn't have time to really talk about my specialty, which is intellectual property, and the impact that has on price. But that chart I showed you, the upswing in price number of people on treatment, if you had another graph of the price of medicines, they would be absolutely the opposite direction. When I was first in South Africa, the cost of AIDS medicine was $10,439 per person per year in Durban. Today, that same medicine is bought for $110 per person per year. Basically, a penny on the dollar. When you have a penny on the dollar, then you can treat people. So we can't have heightened intellectual property protections that actually will increase the cost of medicine in the future. And finally, we have to have community-based services that improve connections to care. Thank you very much. I think all the speakers are supposed to come up here.
Can we get the speakers to come up and sit in the living room?
Yes, please, let me invite all the speakers to come to the front. We'll have a few minutes for questions. We have about 20 minutes for questions and discussions. And as you know, every year the World AIDS Day has a specific theme. And this year's theme is here, shared responsibility, strengthening resolve for an AIDS-free generation. So those of you who are familiar with this terminology of AIDS-free generation, it refers to getting to zero infection, zero death, and zero discrimination. So many countries have adopted this framework for an AIDS-free generation, and I'm not sure whether the US has adopted one. I know that President Obama, for the first time, developed the first strategic plan for HIV in the US in 2010, and it focuses obviously on increasing testing and reducing disparities, among other things. In 2011, there was an article published in the journal Lancet by Quinn and Serwada et al., and the title of that was How You Do HIV Prevention and Programming as a Shared Responsibility. In their assessment, in low and middle income countries, in sub-Saharan Africa specifically, you would have by 2050 that a very large number of persons living with HIV, over 50 million people. And if you are to project the required resources for meeting the needs of these 50 million people, it will be close to $700 billion in low and middle income countries. It is not possible for sub-Saharan African countries or even lower income countries elsewhere to come up with those resources. Hence the need for shared responsibility. And so we cultivate that thing here. So we've had some fantastic discussions here. Today I think one of the things that I had cross-cutting was this notion of human rights, and I think that's a very overlaying thing.
Do we have any questions?
So as I finish up my remarks, I would like to open questions to the audience.
Yes.
Okay, yes, Giduka, Kenyan calling, yes.
Very short one. I think as the last speaker has rightly put it, I think in Africa the biggest challenge we have is not the people who are testing, they are accessing care. But you're having a problem with identifying, with the HIV positive or at risk people getting testing. And I think that's one of the things that we can learn from here. How are you able to identify? How are 80% of the people HIV positive getting tested? And for us, that's a challenge because when you say testing is voluntary, only low-risk people who are not afraid of the results will test. How do you ensure that you capture the high-risk people and they'll accept the results?
Okay, we'll take another question. Yes.
Thank you. My question is directed to Prof. I think perhaps I must say that I also share the same view, that I have a very optimistic view about response in general. But my question is, pertains to this prevention through treatment program or campaign or concept. I think you've said yourself that South Africa is having the largest treatment program in the world. 2.4 million people on treatment. But my question is, the results that have emanated from that have not directly translated to prevention. And therefore, for me, there's no evidence for that at the moment. So I just wanted to get your view on that.
Well, one quick response on the last question is actually the evidence is, there is evidence that treatment at the community level is having prevention benefits. Basically, there's evidence now that for each percentage increase in rural KwaZulu-Natal, each percentage increase in ART coverage results in a 1.3 reduction in incidence of new cases. There's also 11 years addition to the life expectancy in South Africa as a result of treatment. And there's other ecological data which shows that the incidence of new cases, particularly among young people, is decreasing. Now, some of that is treatment as prevention, some of that is increased condom use, some of that is safer sexual practices in general, but I would disagree with that. Just on the question about testing, I mean, we're not doing a great job here, but I think testing literacy and bringing testing to the community is really important. The more you have people come out of the community, talk about testing, the more you have testing community events, the more you take tests to the family, to the community, the more you let people test at home, the more we're going to find out. And right now, if you make it a big deal, and then people have to come back for the results, and then they have to come back for the CD4 test, and they have to come back for the CD4 test results. We need point-of-care diagnostics, easy-to-use tests that are cheap and people can take regularly and easily.
So I'd like to add to the discussion about treatment as prevention, because in none of those discussions do we think about treatment alone, because we still understand that the person needs to be supported in taking their drugs and staying on them, that you need to deal with the gender violence that sometimes interrupts the access to treatment, that you need to deal with other STIs that can promote illness and impact on your immune system. So treatment as prevention is never treatment outside of the context of people's lives. We still have to do all those struggles. We still have to maximize. In this country, we're struggling right now. If you can give pre-exposure prophylaxis, the drug before somebody's actually gotten infected, to control the, not vaccine, to control the likelihood of them getting infected. You can't do that without also continuing to encourage condom use, to deal with mental health status, to deal with substance use. So I think that that's an important piece. The things that were the problems that created risk to begin with are still a problem in terms of treatment as well as prevention.
If I can add just a short comment on the treatment as prevention concept. We have to remember that idea involves the big question of money, and I don't know how many countries in the world, like the US, share that idea of test and treat as soon as someone is diagnosed, to give him the antiretroviral therapy. For instance, the European Union and the AIDS Clinical Society reviews the guidelines for treatment every 2 years. Respectively, a lot of the countries within the EU follow those guidelines, meaning that they will probably not go beyond that recommendations. Of course, in certain cases could be prescribed right away, but in most cases it's not. And the Clinical Society just issued the last guidelines a couple months ago. So for the next 2 years, we would not have test and treat in Europe. And I believe this is because of the cost of resources. Yeah.
I want to make some observations also. As my colleague here mentioned, for example, in the Dominican Republic, we have the situation. We have an outdated guideline that we just outdate, and we just get to 350 CD4. So we try to engage in other prevention activities as treatment as prevention to really support that but within the old work that we've been doing. Because as he said, for us to just to increase to 500, the CD4 will take a long time. And then to put it into identify and treat it, so it will be another time. So we try to also integrate different activities or different strategies to increase our prevention scope.
In my country, for instance, the situation is a bit different. For instance, the PMTCT service in Nigeria shuts out about 70% of women who needs it. The treatment in my country does not cover basically those people who need treatment. So we are talking about new people who are testing positive. There's a backlog of they're not even being able to come for treatment. So that's a key serious challenge. And right now we have instances of substandard drugs, fake testing kits, and so many. So it's a little dicey in our own case.
Let me just start with regard to Kivuka, the testing question. I know you with NASCO and NAC in Kenya, and Dr. Cherutich had talked about how do you increase testing, and that's a key question because I think we see that to be low here. I wonder how it is in Nigeria or in other countries with regard to levels of testing. Those are low, but there are proposals of certain probably examples from countries like Rwanda where you have community-based testing and even self-testing. So I'm aware of funding that has been put to the table by Bill Gates Foundation to do self-testing, and several countries in Africa, including Kenya, is one where there's a study to assess whether people can actually take up self-testing. And I think that would be one way to increase, and I'm not sure how it is in the US whether you can actually do access self-testing kits. Another question? Yes.
My question is for Monchiu, because I'm also Bulgarian, and I was just wondering, my question is more for this part of Europe, because you said that there is a part of the population that has the disease, but it's not official, let's say. And from other side, there is this problem with the funding. So how do you think that in our countries we solve this problem?
Well, like I said, the most effective communities are first men who have sex with men and injecting drug users. At the same time, the numbers of the HIV positive in general are very low. The officially registered cases are about 2,000 in the country and overall. But I'm not sure in what direction your question is, whether how people come out or...
And how without funding we can solve this problem?
There's several options. One of them is through the European Union funding. Of course, the EU says that public health is something that the national governments deal with, and has nothing to do with the European Union as a centralized policy. Nevertheless, some operational programs as the structural funds can do that job instead of the global funds, which is leaving in the end of 2014. So none of the governments in the Eastern European region would be able to fill the gap of the global fund resources. So it will take European Union money to fill that gap. That's the only way I see. Or again, other international donors like Clinton Foundation or PEPFAR or a number of others. Not many options.
Well, I mean, countries can have flexibilities to overcome patent rights and access cheaper generic medicines. I mean, countries may have to take action, like Indonesia has taken, or India has taken, or Thailand has taken. And I don't think it's this is my opinion, but I think you mentioned human rights. The government has a human right for the progressive realization of the right to health. And if they're not spending enough money, that means they should commit more money. If they're spending more money on military than they are in health, then they should start spending more on health. So, I mean, I understand the constraints and people are fighting for the global fund to have a tranche of money that can go towards vulnerable communities in middle-income countries. But I think we also have to put pressure on government to take the steps that they can take.
Denise?
Hi, I'm Denise Warren, professor here at International Affairs. I wanted to speak to the question of self-testing because I know this has come up a few times, and I'm curious about this move towards self-testing. In the early 90s, I was an AIDS activist in Omaha, Nebraska. I worked for the Nebraska AIDS Project. And at that time, this was about 92, 93, Johnson & Johnson had put out a home testing product in the United States. And I don't think that it was widely distributed, but they started out in the Midwest. And what we found was that the home testing kit was really problematic in the sense that there were lots of false positives. The product itself didn't give people the access to information that they would need if they tested positive. The numbers that they included with their packaging were all incorrect. And that we felt was really dangerous for the community itself. So we actually I wrote a piece of legislation for the Nebraska legislature that would force the Johnson & Johnson to put a sticker with our hotline on it. And of course, they took the product right off the shelf because they didn't want any sort of suggestion that there was anything wrong with the product. So my question is, you mentioned in Rwanda possibly doing self-testing. How will that also offer the kinds of services that people would need after finding out they're positive? Would it also include some sort of community support? What we found, at least in the case in Omaha, was that once we did sort of community testing events, going out into rural communities where people were pretty closeted about this whole issue, that was a much more effective way than sort of, Professor Baker, you mentioned that as well. It was much more effective than relying people to do it by themselves, which turned out to be kind of not the best thing. So I'm just curious about the program in Rwanda because I hadn't heard about it.
Let me just mention that actually, Denise, this is a proposal that I wrote with colleagues earlier in the year, and unfortunately we didn't get selected for funding. And the project basically is covering 8 countries in sub-Saharan Africa. It's funded by Gates and a group called 3IA, which is an impact evaluation program. And so we looked at some literature, right? So there are countries like Uganda, Rwanda, where this idea has been promoted by the Ministry of Health. And in Kenya, there was a study done in Kenya among health workers that showed high uptake of self-testing, in which you look at health workers, nurses, and doctors. And so give them these tested kits, and they go home with them, and then so within 24 hours have they tested. Within a week, how quick have they been able to do self-test? And uptake was about 80% among health workers. So based on that, and based on observations in Uganda, where these self-testing kits were apparently available in some pharmacies, and people would go and buy them, the Gates was interested in trying to build up, increased testing, and perhaps if you use self-testing, how likely is it that people can uptake that? So in the design of the study, we had selected several community groups in urban and in rural areas, and then we would look at those and try to basically assess the willingness to self-test. So, and in Uganda, there were challenges observed, and you're right, if I test at home, then what is the link to care next step after that? And I think that's a major challenge that may still need to be overcome. I don't know if somebody has
just one other quick response to that. I mean, the technology has improved, thank goodness, and the willingness to try to connect people to care. The more you have community-based services and awareness in the community, you've done treatment literacy, you've done testing literacy, then people know that the need to connect to care. You can, and community health workers can come around, et cetera. But the other thing is, we need people to test over and over again. Testing, knowing your status once just isn't good enough, and that's actually a problem with the way a lot of testing campaigns have been run. In South Africa, they really need to have testing almost every year, at least every other year, in order to really detect the cases. And there's lots of acceptance. It's not the only way to test, but if you're testing the 3rd or 4th time, if you're doing it every year, why do you have to go back into a doctor's office, have that inconvenience and extra cost when you can do it at home? As long as you know what you're supposed to do if you test positive, then that's a convenience for some people.
I must speak for most of the Latin region. Most of the countries of the Latin region, if not in all, you need to do the pre-counseling, the test, and the post-counseling. It must due to the cultural things, cultural aspect, because the approach that programs have is not to the general population. So even though that, as my colleague said, people can like test one or twice, but there is a huge amount of the community that does never get access to tests, so it's the first time. So maybe it will be different than in other countries that the strategies is abroad and cover the whole country, but in most of our country, you just cover 1% of the population, so you have to really to link when you do the test to reassure that they know what they're doing, and also link to the service in case it came positive, and in case it came negative, to really ensure them to do it again another time.
I think what is important in most cases is that the knowledge base in each country and community. For instance, in the US, there's a lot of awareness and knowledge about HIV. In most African countries, we have the awareness, but the knowledge is not there. In the absence of the knowledge, even when you test positive, there's tendency for people, like we find in my own country, for self-medication. People treat themselves for serious issues where they're meant to consult the doctor. So if that is allowed, I don't know what prices we might face.
Okay, Bob.
So this is a question to all of the panelists or anyone in the room, but I'm particularly concerned about sub-Saharan Africa. To what extent do people turn to herbal medicine and traditional healers ostensibly to deal with HIV/AIDS, because they do to deal with diabetes and a whole bunch of other conditions?
In fact, it's a real serious problem. Not just the traditional medicine. Another big challenge, another focus is religion.
Yeah.
There's so many centers saying they are having miracles. And what we have found out is that a lot of, because the prevalence rates in Africa is basically from the mothers, pregnant women who turn up in the hospitals. They will register first at the hospital, they will do some antenatal, but they will never deliver in the hospital. Why? Because some of them they're afraid that if I turn positive, what will happen? So they prefer to go to traditional birth attendants and they deliver in their churches. So it's a real big challenge, and now there are a lot of interventions by NGOs and governments targeting traditional birth attendants. But again, one thing that we have to have in mind is that majority of the people who are affected in Africa are in the rural areas where we don't really have clinics. You know, what we believe what they do is the traditional people. And they are the main people. 60% of in my country of the population lives in the rural areas where there are really no clinics. So so that is they still patronize them so heavily, and it's one of the big challenges that we have, because no tests get done there. No tests. They don't test for HIV. They don't do anything, and there are so many people even trying to make money out of the fact that you are HIV positive.
Let's have a comment.
Yeah, concerning the herbalists and traditionalists. For instance, in my hospital, we have a success story where people are very ill with opportunistic infections. They come and they are being treated, they get better. The problem is adherence. When they get better, they go back home and then they turn back to these religious bodies. And then they tell them you are healed, you don't need any medicine. So they stop taking their drugs and then they get worse. They come back in the worst state. Sometimes they come back and die. Sometimes they even die in the car before they get to the hospital. So it's a big challenge for us.
Okay, if we do not have one comment, okay.
Yeah, I just wanted to ask Darwin a question to you. So one of the discussions that cropped up during my discussion with one of my professors who visited South Africa extensively is the fact that in South Africa, I think that the rate of HIV infection is much higher than it is in Nigeria. And one of the things I wanted to know is that because in Nigeria, I think that the social stigma that's associated with being HIV positive is still pretty high. So what is the current situation in terms of social stigma? Is it declining, or is it constant, or is it increasing in Nigeria specifically?
In Nigeria, stigma is a big challenge, and it's everywhere. It's everywhere in the home. in churches. We have instances where people have been asked to come to church again. We have instances where schools have relieved students of their admission. We have instances where employers have sent some parking. We have instances where private hospitals have refused to deliver women who are HIV positive. Is really a big thing. It's really a big thing. There's no acceptance of that reality. There's still so much misconception, about what HIV actually means, and largely that's a key problem we have with our media, because people are really not educated. People look up to the media, the radio station, the TV, and the newspaper to get, and even in the media, when you look, I do a lot of content monitoring of media reporting of HIV/AIDS. When you see the media reporting HIV/AIDS, you run, because it's serious. But I must say something. You refer to South Africa as having the highest there's stigma in South Africa. But one thing we should note is that South Africa, Nigeria is 3 times in population of South Africa. So if you look at the absolute number, Nigeria probably have a bigger problem than South Africa. And one important issue is that South Africa has a better intervention. South Africa have over 2 million people on treatment. Nigeria have less than 500,000 on treatment. And we have a population of 3.4 million people, who are HIV positive. And that figure is inaccurate. Okay? It's a speculation. Because I know that in Nigeria, less than 2% of the population have ever tested. Okay? So it's a serious challenge.
Okay, one last comment, and then I'll invite Jack. Okay.
I want to ask a question.
Okay.
Yeah, can I ask a question?
Sure.
To the professor, in this slide, I want just to break the prevention to HIV into 2 parts. One is treatment as prevention, and other is the prevention itself as prevention. So in your slides that you've shown the use resource gap, and to reach to that near to 10 million number. There's use gaps, and we're talking about universal access to all HIV positive, and there's what are the question of sustainability, and what are the strategies to the sustainability to for the HIV positive as part of treatment, and how would it be possible in this resource gap, and other is the prevention itself as prevention, the behavior change and the condom use. Where treatment as prevention is also promising, I know it, but the prevention itself, the behavior change and the condom use, that in the history of Thailand shows 100% condom use decline the incidence of HIV by use number. So how do you compare these 2 sides of coin, one treatment as prevention with the limited resources, and other the prevention itself that we're trying to miss it while we're only looking at treatment as towards the treatment as prevention, these 2 sides, how would you compare it?
So a quick answer, because we're running over time. Treatment as prevention can't be the entire response. I think Jean said that. Medical male circumcision is highly cost effective. It's a one-time intervention. We need to reduce violence against women. We need to have better support for children and their access to treatment. There's lots of things that we need to do. But I do challenge us with this idea of scarcity. We have this sense where we can't save someone's life and prevent the next person from being infected. I just think that's the wrong math. I think our governments tell us that, rich people tell us that, but there's no inherent logic that says, we should be spending more on nuclear submarines than we do on preventing and treating HIV. So my challenge back to your question is, why do we always think we have to subtract from something we know people need because someone else says there's not enough money? When we look around the world, Bill Gates was at the White House today when President Obama gave his World AIDS Day talk. This is a man with tens of billions of dollars in resources. which basically he got from intellectual property protections. I'm glad he invests a lot of it in public health, but it's simply not true that he and a lot of other rich people couldn't contribute way more to the public good than they currently do and take far less. And the other thing is we do have some access to get things more cheaply than we're currently getting them. Thailand issued compulsory licenses to get access to AIDS medicines and heart medicines and cancer medicines. It was the smart thing to do. And then your government changed and it's gone back from that policy. Well, people should continue to fight for that policy and get time out. So, anyway.
Jack,
All right, Jack, please.
Close it up.
Well, I just want to take a minute to thank our panel and everyone who's been speaking tonight. It was a wonderful opportunity. I think this is a rare opportunity to see so many different cultures brought together and so many different faces on the problem. I know that the panel will be standing around for a few minutes if you have additional questions, and we have be able to talk a little bit. And then I do want to give them a little bit of a break. This is their third session today they've been to, so the poor people are tired. So thank you again for all of you.